am Michelle Rice, Senior Vice President of Public Policy and Stakeholder Relations with the National Hemophilia Foundation. I'm pleased to be able to discuss opportunities to optimize quality and cost of care for health plan patients with hemophilia with Dr. Scott McClelland. Dr. McClelland is the Vice President of Commercial and Specialty Pharmacy Programs at Florida Blue and is responsible for 1.4 million pharmacy lives. Hello, Dr. McClelland. My first question is, from your perspective as a health plan pharmacy executive providing care for patients with hemophilia, how have payer policies and methods evolved and adapted to a changing healthcare environment?
Thanks, Michelle, for giving me this opportunity to discuss these questions. So from my perspective, policies have mostly remained unchanged, providing relatively open access to hemophilia products. I would say that PBMs and payers have moved to a more narrowed pharmacy network in order to ensure members are getting the appropriate support, care, and education needed for these products. In addition, I think narrowing the network, payers can collaborate with preferred pharmacy providers to ensure members' compliance is maintained and tracked, member outcomes as to facilitate discussions with the members' physicians, if required, to ensure the appropriate care plan is in place.
Well, what do you find are the critical barriers to optimal patient care, and how can they be addressed?
So I definitely think patient compliance is a really big one. These individuals need continuous encouragement and support to ensure appropriate management of their medical condition. Remembering that many of these individuals are very young, it can be challenging for parents and caregivers. In addition, trying to maintain a normal, active lifestyle while minimizing risk can be very challenging. I think another critical barrier is overcoming inhibitor development. And finally, additional research is really needed to determine the appropriate dosing and levels to ensure optimal outcomes. So, Michelle, do you believe these barriers align with your concerns that you hear from the providers and the patients? And can you share some examples of situations where these barriers were successfully addressed?
Actually, yes, I would agree. I hear from a lot of providers concern around patient adherence and how to be able to monitor that and make sure that patients are staying true to their treatment regimen. And I think that some ways that has been addressed in the past is there's been additional tools created to make it easier for patients to log their factor usage and their need for factor replacement. So if it's a prophylactic treatment versus a traumatic injury type situation. So I think that that's helped improve adherence. I think one of the other things that I think has helped improve the adherence is that the National Hemophilia Foundation has really provided a lot of education to the patients around the importance of adherence. And so I think that has definitely helped. I think some of the newer products, some of the options that are out there for patients have made treatment more convenient and also allows for the patients to experience better outcomes as well. But I think that you hit on one of the big questions, which is dosing and understanding how that differs from individual to individual, because this is a really unique disease to the individual. So obviously I think there still can be more work done on that. What do you feel are some key communication methods and tools that could maybe link health plan and or specialty pharmacy strategies with Hemophilia Treatment Center strategies in a way that improves their alignment and helps maybe lead to some consensus on treatment regimen approvals like prior authorizations and comprehensive care methodologies?
So thanks for asking. I think first and foremost, establishing a good connection within the various hemophilia treatment centers and or having a single individual that can facilitate discussions is very critical and optimal. And I can tell you that working with you, Michelle, has been great. You know that I have an open door policy and you can contact me anytime to discuss any insight that you have or issues that may be occurring. And so I think, again, establishing that connection and that relationship is the utmost critical step.
Thank you, and I agree. It has been excellent to be able to work directly with you. One question along those lines, you had mentioned kind of having a single person to contact or a main point of contact at the hemophilia treatment centers. Is there typically within a health plan kind of that individual contact on their side as well? I mean, I know in working with you, I'm able to reach out to you, but realistically, is there within customer service or within some other place in the organization, could there be a key contact for these providers?
So I think it's always an opportunity to develop better processes, and I do believe that there's an opportunity to establish a centralized gateway for these questions that come in, knowing that it varies across the payer population. I know there's other PBMs and payers out there that have direct connections with HTCs as well, but there's always opportunity to improve the process, and it would be great to work together to establish a process.
Can you describe the type of data and documentation that would help to convince you or another payer of potential cost savings that could be achieved through incorporating the comprehensive care model delivered by an HTC for your members with hemophilia? We hear a lot that we need to be sharing more data. There just seems to be a question as to what does that data look like?
Of course, and thanks for asking. Our number one concern, of course, is member care. So the outcome data is critical. We really want to know how these patients are doing, the number of bleeds, if they're adherent or not, hospital admissions, what their total cost of care is, and how many patients have developed inhibitors. And we also want to understand if there's barriers that can be overcome or if there's challenges that these individuals are facing. Last and very important is that payers really want a trusted partner, since this area of care has been riddled with a lot of waste and expense over time.
Okay, I appreciate that. I believe you're aware that the National Hemophilia Foundation has partnered with Impact Education, and we're doing a initiative called the Comprehensive Care Sustainability Collaborative, where we're working with some other payer groups to ask the same kind of question, what kind of data? And it's been very interesting for us. And I think that what we're learning is there can be such a thing as maybe too much data at the same time that there's not enough. And so I think some of what you've just said fits right in with what we're hearing is, can we explain how many hospitalizations these patients are having, how many ER visits are they having, and how many of those were maybe avoidable if the patient had been adherent to their treatment regimen, or if that treatment regimen had been fine-tuned so that it was appropriate for that patient. Does that sound like what you are looking for?
It does.
Along those lines, what are some of the key implementation processes that managed care organizations, payers need, that maybe you use in other high-cost diseases such as cancer, that could be maybe adopted system-wide that would reduce treatment variability through the promotion of the comprehensive care model?
So that's a good question. I think the first thing that comes to mind is the data and guidelines and pathways similar to what you see with oncology protocols. So establishing clear pathways with how to treat these individuals and when to go to additional agents and whether to use things as prophylaxis or active treatment, what doses, etc. And I think, secondly, value-based arrangements with providers to ensure that appropriate management is being provided and that there's the follow-up and oversight needed to manage these individuals.
I know this is something that I hear is an issue for patients and providers. Could you recommend a way for hemophilia providers to streamline the pre-certification and prior authorization processes that plans often require?
Sure. As I mentioned previously, if health plans were able to establish value-based arrangements with key providers, focusing members to these trusted individuals and removal of the prior authorization requirements could be considered. I think in addition, if the hemophilia community would join the payers to voice their concerns regarding the rapid and unsustainable pricings for these agents, that would be a huge help. But overall, I think these trusted value partnerships that we could establish with select providers or key credentialed providers is the first step into being able to do that.
Well, I know that you have been very willing and open to communicating with the National Hemophilia Foundation, and I think we try to serve as maybe a conduit for that relationship with the HTCs, and also, obviously, our goal is to much like yours, to ensure healthy patients. And I think we talked about the possibility that maybe having a dedicated contacted health plan could improve communications as well. Would you see that, as you had mentioned, having a designated person at the Hemophilia Treatment Center, would that need to be a contractual relationship? Would that just be this is your point of contact? Or how do you see that working? Or on the flip side, if there was a specific customer service team at the health plan that dealt with hemophilia patients or hemophilia questions or referrals, or is that something that would be part of a contracting process with a Hemophilia Treatment Center, or is it more just of a recognized, here's your main point of contact?
So I think it could be worked in several different ways. Definitely, as we work with Hemophilia Treatment Centers and contract with them, we could establish a key account person for individuals to work their issues through. I think that's an excellent idea. Again, I think still the communication is critical, so establishing that relationship with these individuals and designating a certain individual or area and dedicating a direct phone line, open door policy, email, etc., that can be responded to quickly as needed is key. So I think it can work both ways. It's ideal probably to establish it through a contract method so that you've got the phone number and the individual's or the area's name and then establish a protocol for the process. But it can be managed either way.
Well, I think we both agree that the key to any of this working is communication. What would your overall vision be of ideal disease management and provider-payer relations in the future as it relates to hemophilia care? Or I think we may have already hit on that a little bit, but how do you think we could make some of those connections?
So I think my overall vision for ideal disease management would be a cure, right? Short of that, I would say improved products that maintain adequate levels of circulating factor, establishing a network of very knowledgeable and trained providers that is supported by similarly focused pharmacies can help ensure optimal care. Establishing that communication pathway that we just talked about is very critical so that urgent issues can be resolved, that develop that trust between the HTCs. Member education is key as well. I think tracking and reporting the overall management of these individuals and the outcomes and showing what works and doesn't work is really critical. And then again, reducing as much waste out of this space, given the high cost of these agents, is very important. So working together, I think all of this really supports a ideal collaborative model, working with the physicians, the payers, the HTCs, and the various advocacy centers, ensuring that individuals are educated and that we manage their disease state to the best that we can.
And I guess finally, I would ask, how do you think that an organization, an education, advocacy, or research organization like NHS can best assist you and some of these other stakeholders in accomplishing the vision? And what do you see as our role?
So I think first, understanding that payers and the National Hemophilia Foundation are aligned with their focus to ensure appropriate care for these individuals is received. And I think second, the willingness to collaborate on opportunities within the space is critical. So I think that's what I would say would be the key opportunities and vision for this space.
Well, thank you very much for your insightful comments and for your willingness to participate with us today.
Thanks.